Hi, my name's Corey Langer. I had the privilege of chairing satellite symposia on wild-type population with advanced metastatic non-small cell and the role of checkpoint inhibition frontline and treatment strategies in the second-line setting when checkpoint inhibitors no longer work. My day job, I'm a director of thoracic oncology at the Abramson Cancer Center at the University of Pennsylvania, where I'm a professor of medicine. It was my privilege to be the chair of this exciting session. Dr. Philippe went over the current treatment paradigm for advanced non-small cell, the emergence really over the last 3 to 4 years of checkpoint inhibitors as the standard of care in this population. Now, this is specifically the wild-type population. These are folks, patients who do not have actionable molecular aberrations, so no evidence of EGFR or ALK or some of the lesser or less common translocations and mutations such as BRAF or ROS1. In aggregate, it's the vast majority of patients we see, probably close to 70 or 80% of all patients seen outside of East Asia are quote-unquote wild type, no actionable marker. And there, historically, chemotherapy alone was our standard. And really, for about 20 years, we were wandering through the therapeutic wilderness. Our standard for squamous cell had emerged as a platinum combination, usually carbo with taxane or gemcitabine, and for non-squamous over the last 10 to 15 years, similar combinations, but with pemetrexed. Unfortunately, we had made very little headway. In 2015, 2016, as discussed by Drs. Hagener and Philippe, the checkpoint inhibitors targeting PD-L1 emerged as a viable and preferred approach in the second-line setting across the board. Nivolumab, pembrolizumab, atezolizumab clearly resulted in superior outcomes compared to docetaxel, higher response rates, generally, although not always, better progression-free survival, and consistently improved survival. And within 6 to 12 months, checkpoint inhibitors became the standard of care in the second-line setting. So it was a very small step then to assess these agents in the first-line setting. Preliminary data in the first and second line setting, both in phase 1 and phase 2, it suggested that agents such as pembrolizumab might be particularly effective in those patients who had very high PD-L1 levels. And as Dr. Philippe has reviewed, pembrolizumab in that group, based on the KEYNOTE-024 trial, clearly proved superior to chemotherapy alone, to histology-based chemo. And within 6 months of that presentation in 2016, it became essentially the standard of care world over in that population. If we look at the numbers, it's roughly about a third of the patients that we see who are wild type, who don't have actionable mutations. More problematic, of course, has been the two-thirds who have lower levels of PD-L1 expression, and there have been a number of trials that have emerged over the last 2 to 3 years through 2019 that have clearly shown superiority for chemo in combination with pembrolizumab compared to chemotherapy alone. The KEYNOTE-189 trial in non-squamous non-small cell and the KEYNOTE-407 trial looking at taxane-based therapy with carbo with or without pembrolizumab. We've also seen data for atezolizumab in the same setting, the Empower 150 trial, showing clear superiority for the 4-drug combination of paclitaxel, carboplatin, bevacizumab with atezo compared to the bevacizumab combination alone. And again, this was the one trial that actually looked at patients whose disease had progressed on prior tyrosine kinase inhibitors. So unlike the trials conducted with pembrolizumab. This is one exception. It included patients who had whose disease had failed prior TKI, but who had actionable mutations. Did not exclude those individuals. Similarly, there was another Empower trial that looked specifically at non-squamous combination of taxane with atezo and carbo, looking better than pac carbo alone. Again, survival advantage. So in very little time, we have completely upended the treatment paradigm for advanced non-small cell. It's no longer chemotherapy alone. For those with lower levels of PD-L1 expression, less than 50% or no expression, chemo in combination with a checkpoint inhibitor in patients who are fit enough is the standard. And for those with more than 50% expression, single agent pembro is probably considered the standard of care, although there's a big question whether the triplet, chemo plus pembro, may in fact be superior to pembro. And there are ongoing trials, including the Insignia effort in North America, a combined effort of ECOG and SWOG that's actually assessing whether the triplet is truly superior, whether we can get by with just a much less toxic single-agent checkpoint inhibition. Unfortunately, the vast majority of these patients will have disease progression. How to handle that is a major challenge. When checkpoint inhibitors emerged as standard second-line agents, docetaxel was sort of relegated to third-line, or in some cases, clinical irrelevance. But now that we've introduced the checkpoint inhibitors into the first-line setting, docetaxel has become more important again, and it becomes our standard, in some cases, default option in the second line. And here, the question exists whether adding an angiogenesis inhibitor to docetaxel might be superior. We know in the pre-checkpoint inhibitor days that the REVEL trial combining ramucirumab with docetaxel clearly showed therapeutic benefit compared to single-agent docetaxel, higher response rate, higher progression-free survival, and higher overall survival, and probably would have emerged as the standard of care had the checkpoint inhibitors not taken over the second-line setting. But with checkpoint inhibitors moving into the first-line setting, that regimen becomes incredibly important. And there are now some data looking at that combination in patients who have had prior checkpoint inhibition, gauging the overall response rates, and also retrospective data from the REVEL analysis that shows that patients who develop rapid progression on the original chemo regimen may actually preferentially benefit from docetaxel and ramucirumab. That if we look at the forest plots, the hazard ratios for progression-free and overall survival are particularly good in that population when they are then challenged with a docetaxel-ramucirumab combination. There are similar data for nintedanib, TKI in combination with docetaxel, again in the same setting. But this is an area that is wide open for additional clinical research. In patients who've had a response and then have smoldering progression, certainly there's a potential role for looking at new combinations of checkpoint inhibitors with other immunotherapeutic agents. And in patients who've been on maintenance pemetrexed and pembrolizumab, there's increasing interest in reintroducing platinum, re-challenging with carbo, since they had not had disease progression on that agent, swapping a different cytotoxic, say a taxane for the pemetrexed at that point, and then perhaps relooking at angiogenesis inhibition. And there are now ongoing trials looking at what I call the second chance platinum-based regimens in the second-line setting, which we had not previously assessed, at least not in non-small cell. So it's an exciting time to be a thoracic oncologist. New treatments are emerging. We are now, for the first time, seeing much greater benefit to our patients, much higher response rates, much greater, much longer progression-free survival, and in some cases, durable survival without progression. I hesitate to use the C word for cure, but clearly, many of us, those of us who spend a good bit of our careers focusing on thoracic oncology, are seeing patients now alive at 3, 4, 5, 6 years without disease progression thanks to checkpoint inhibitors. So it's completely upended our expectations, and it's important, I think, based on this symposium, based on the data that are emerging, to combat the therapeutic nihilism that is so rampant, particularly amongst our colleagues.